Council. Oh, I know there's a requirement that council officers have to address me as Councillor Willoughby. For anyone who's not a councillor, my name is Rob. I have no problem in anyone just calling me Rob. That's fine with me. Yeah. So I am retired, so I can spend lots of time here, which is what I tend to be doing these days. So if we could just have a run round, please, I'd be grateful.
Hello. Public health here at Thurrock.
Good afternoon, everyone. I'm Tom Abel. I'm Chief Executive of NHS Essex Integrated Care Board.
Christopher Smith, Programme Manager, Adult Social Care, Thurrock Council.
Margaret Allen.
Hi, I'm Natalie Amos, the Service Manager for Open Road Young Persons Drug and Alcohol Service, and Service Lead? Yeah, Service Lead.
I'm Michaela Fullett-Monk and I'm the Service Manager for Thurrock Open Road.
I'm Beth Capper. I'm acting in the Consultant in Public Health role here at the Council.
Hello, I'm Milena Bingley. I'm Councillor for Greystown.
Marion Cherry, Councillor for Little Thurrock Rectory Ward.
I'm Mark Graver from EPUT. We are the Mental Health and some of the Community Services Trust. And I apologise, Chair, I'm going to need to leave about 20 to 4 today.
Hi, I'm Jody Ramcharita. I am the Assistant Director for Set CAMS, which is NELFT, representation for mental health, children and adolescent services.
John Veazey, representing the Thames Port, so it covers Thurrock, Barking and Dagenham and Havering councils.
Louise Banks, representing Mid and South Essex Foundation Trust.
I'm Sheila Murphy, the Exec Director for Children's Services in Thurrock.
Good afternoon, my name is Jim Nicholson and I'm the Independent Chair of the Thurrock Safeguarding Adult Board.
I just realised listening to you, I didn't say who I am. Rob Willoughby, but my borough that I'm, the ward that I'm the councillor for is Little Thurrock and Blackshots. But as you probably all realise, I'm also, I've got the cabinet role for adults, health, social care and housing. So, do we have any apologies? We've got apologies so far from Councillor Linda Benson, Rob Percy and Mark Tebbs. Are there any other apologies anyone else wishes to bring to our attention, please?
Michael Deneen.
Who keeps the minutes?
Me.
Oh, okay. Can you write down Michael Deneen? Okay, so the next item is item 2, which is the minutes. Minutes of the March board meeting are provided on page 5 to 14 of the meeting papers. Hopefully you've all had the opportunity to review them. So I would ask, do any members agree the minutes of the March meeting as an accurate reflection of the meeting? Obviously there's a few of us here that can't comment because we weren't here. But those who were here, do you agree that they are here? Yes. Do you normally do a show of hands or do you just do a nod?
Yes.
Okay, thank you very much. I take it they are therefore approved. I'm told, because I've got really good copious notes here of what I have to say and what I have to do, that there's no urgent items have been raised in advance of the meeting. And now we come to item 4, which is declaration of interest. Is there any member wishes to make any declarations of interest per the flowchart on page 3 of the report pack? No? Excellent, thank you very much. So now we come to, I guess, the real crux of the meeting, which is the NHS Essex ICB update, which is also in the pack that we've got. And as far as I can see, we have 10 minutes for the presentation and 10 minutes for the discussion. So I think it's over to you, Tom. And
thank you. Yes, so I'm not going to do kind of death by PowerPoint. You've got that within the pack, but I thought it would just be worth firstly just giving a quick update on where we're at within the Integrated Care Board. And for colleagues who are not aware, the way that the NHS is structured is that there are integrated care boards which cover all parts of England, and they are the organisations which are responsible for effectively organising, funding and commissioning NHS care for designated population. So that includes everything from your very specialist hospital care through to primary care and general practice services and everything in between. We've recently gone through quite a significant reorganisation of integrated care boards with the aim of reducing the running costs of those organisations, as part of which we saw the creation of NHS Essex, which brought together what were 3 different ICBs serving different parts of Essex. That organisation was created on the 1st of April this year, and we're now kind of moving into kind of the delivery stages of that work. Within the slide deck that we've shared, we've kind of set out what we see as being some of the key priorities for the health service over the coming years in terms of the work that we need to do to improve access to NHS care and services and improve outcomes from those services across all parts of Essex. The work that we have embarked on here in Thurrock but we need to continue to accelerate around how do we shift more of the care that's currently people are having to go to hospital for into community settings. So what can we do to strengthen general practice, improve access to general practice, and make sure more specialist advice and support is available so people don't have to go to hospital if they don't need to, and the work that we need to do in terms of making sure that we tackle some of the premature mortality issues that we know that we have in some parts of Essex, particularly around people who die too early from cardiovascular disease, cancer and respiratory disease. So we've worked hard in terms of kind of continuing to flesh out that population health improvement plan that was previously seen around this table, and clearly it is something that we'll be working with colleagues from all of our local authorities on, because there's clearly a crossover in terms of the work of our different teams, and we're committed to doing that. However, when we did publish the plan, we also recognised that because we had to produce it in fairly short order, that we also needed to make sure that we listen to local residents as we continue to develop that plan. And so later this week, we will be starting our work around broader public engagement and listening in terms of understanding what are the key priorities for residents, what have we missed in the plans that we've got in place at the moment, and what more do we need to do. And so if you do see that, please do participate, because it will be important for us to see that. The other piece of work, which is a slight update on, is the thinking around some of the geography change. So we've now got an Essex ICB. We also know that in the policy direction to the way the NHS is going is that we're going to be seeing, we're going to need to see the way that the NHS is organised at 3 different scales. So one of those being at an Essex scale for your very specialist services, those services that it's difficult for us to split up in multiple ways. A multi-neighbourhood footprint, so bringing together a place. At the moment we'll be working on a Thurrock footprint, but clearly within the paper we've kind of got an eye to any potential future changes around local authority boundaries, and then also at a single neighbourhood level. And so those single neighbourhoods are set out within the pack and work we previously discussed, and so this is how, building on the great work that we've currently got in Thurrock around the local teams that are working between health, social care and the wider council and other voluntary services, the work that we can do to support local communities closer to home. So that work continues, and the aim is for us to start to accelerate some of that work over the course of the summer, particularly looking at what we can do to better support frail older people in our communities, and so preventing them from having crisis events and ending up in hospital and all of the resultant impact that has. We've also, since we've last met, submitted on a national request around the creation of neighbourhood health centres in Essex, and so the government and NHS England put out a request to all ICBs on the 15th of April for us to submit our proposals around new or refurbished neighbourhood health centres across all parts of Essex. There's an update in the pack on that. Of particular interest to colleagues in Thurrock is we have put forward the Thurrock Community Hospital site as being one of those potential locations for a new neighbourhood health centre, which would bring together a whole range of services with the intention of looking to move services out of the hospital setting. We're waiting to hear back now. We've made that submission in terms of what the next steps are on that, but we will keep you engaged. And there is also an update within the pack about the work that we've previously briefed this board on around the convener model. So that's our work, that's our aim to work differently with the voluntary community and faith sector to move to a much more collaborative approach, recognising that community organisations often are much better placed to understand what are some of the issues facing local communities and moving away from a less prescriptive approach to the way that we allocate funding within the ICB, and that we're continuing our informal consultation with the sector over the course of the summer, and we aim to be able to launch this new way of working next July is the plan. There's quite a lot of detail that has to be worked through before we get to that place. There's also finally a bit of an update around the work that we're doing on planning, and so particularly think about how do we make the Section 106 and SIL process work better to recognise some of the challenges that we've historically had around the delay in the establishment of particularly new primary care, so general practice accommodation, where there has been big new housing developments and things like that. So we've been working with planning officers from across all parts of Essex to kind of reset that approach and to work quite differently, so we can start to see as new developments are established. In parallel, we're starting to ramp up the general practice access and the other access that people need locally, and so there isn't this big disjoint that there has been historically around. There's a big new housing development, but it takes years for the GGP practice to land in that place, and so we will be in a place over the course of the summer whereby we've got a really clear sense in terms of all the planned future developments, and then the parallel kind of primary care NHS estate development work, and so we can get ahead of some of those issues and challenges. I hope I haven't used all of my time or overrun my time, but I'm happy to take any questions.
Bringing this, it's really helpful, and I think kind of welcome the updates because there is so much work going ahead and at a very fast pace, I guess. So just really wanted to say thank you. I guess just one or two things just to kind of I'm trying to get to the slide. I guess it's really helpful to see the public health slip of the tongue, population health improvement priorities. And just obviously with local authority we have our services set out, but I'm in all of this I'm thinking there's lots of focus on children's as well that's embedded in this, but just want to really pull that out because core 20+5 indicators for both adults and children, and a lot of the other kind of points, I'm imagining are embedded through this as well.
Yes, so children is entirely embedded within it, and indeed we have a very specific chapter around children's health within the population health improvement plan, and we specifically picked out the improved school readiness kind of measure as something that we see as being really important in terms of making sure kids get the very best start in life, because we know that if we can tackle some of the challenges there, improve school readiness, actually people's life chances improve significantly, and so we can make a really disproportionate impact if we get that right. And it is work that our children's team, I know, are working with Sheila's team on and colleagues from across the county, because we need to do it together if we're going to make the difference we want to see.
I was going to ask something about if you're a resident of Thurrock, because there's been really significant changes for the ICB, including funding changes, so considerable funding has been removed. So what, if you were a resident, what would you notice, or what would you like them to notice? You know, I've got a children's hat on, but I think that's generally for all residents, you know, because this is talking about better access. You know, I know there's sort of problems with GPs. I don't know how, if that's improved. You know, oral health is a really big thing, certainly in children's services. I'm not sure if that's across the whole system. But it was just sort of on my mind of thinking, if you're a resident, how is this different, better?
So this year we have a very specific focus on access. So it should be easier for you to get a GP appointment when you need to, and to communicate with your GP, be that in person, over the phone, digitally. In terms of dental, we actually have got very good, well, relatively quite good dental provision now within Thurrock. Now, one of the pieces of work we need to do is we need to get better at promoting the access to that, because I think because there has been challenges historically, people think you can't get an NHS dentist, and so you don't try to get an NHS dentist. And so we've got more work to do on that. And also there's still a lot of misunderstanding in terms of you have to be on a dentist's list, which that model went out years ago in terms of you can go to any NHS dentist in the country, actually, indeed, if you so wish, and they can make you an appointment. So we need to do some work on that, and also we need to do a bit more promotion around some of the other access, some of the other ways you can access service. So you can now call NHS 111 and get a dentist appointment, and you can also get an emergency dental appointment also through NHS 111. So now we've got that all in place, we now need to promote it so people are using it. I went to the new dental practice that's actually just over the road from here, and that's one of the things that they've been really working on, is in terms of people being aware that the service is there and they can use it. So I think access, and then we're working very closely with our kind of more community and secondary care providers around equally also improving access to more specialist services. And so specific work around community services and access around ADHD, ASD diagnosis, and so we've brought in significantly more capacity, and we're starting to see that waiting list come down. The work around hospital access, so our aim is to see a reduction of around about 40,000 patients we're going to try and remove from the Essex waiting list over the course of this year, and the introduction of other new services to help avoid the need to, so we've got a new musculoskeletal service, so physiotherapy, that kind of thing, which is now, that came online on the 1st of April. We've got a new dermatology service which started in February, which again is community based. We've already seen, as a result of just those two things alone, 4,000 less people being referred to outpatient services than would have been if those services didn't exist, and that frees up capacity as part of that process. So the big focus on access. The second area, and this is going to take a bit longer, is that shift in terms of, so how can we begin to get services organised in a way that they're organised around people as opposed to individual service silos, and so particularly thinking for anyone living with frailty, anyone living with a long-term condition, how can we organise that service much more effectively? So we're going to try and start to pilot some work, as I said, around frailty this summer to inform then where do we go next year onwards, because it's going to involve us working differently with general practice, with community service and with secondary care services, so we need to learn from that. And then longer term, if we get that right, get the access right, start to tackle some of the issues around long-term conditions, start to get some of the prevention work really working effectively, you start to then see the outcomes change more broadly. But you kind of got to get those things right first before you can move on to that next set of things. So yeah, so we're not trying, we need to move at some pace, and I think we are doing that at the moment. Yeah, but lots to do.
I guess also it's helpful for us to get a broader strategic picture across Greater Essex, because patients and residents move across boundaries as well, and it's just important to recognise there's a lot of work going on around neighbourhoods and how you can access services more locally, but for more specialised services, you do have patient or resident flows. And I guess at some stage, once North East London ICB are a bit further down, because we might have some Thurrock residents that access some services across the boundaries, and at some stage when it'd be good to have that understanding if there's any impact on Thurrock residents, but we'd look to yourselves to let us know if there is anything further along the course of the year.
Yeah, of course.
Is there any other questions? Can I ask you a question then, please? We hear all the strategy, fantastic, yeah? Very simple question, I'm now just putting my ward hat on, if you like, yeah? Very simple question we keep being asked is, when are we going to be able to get a doctor's appointment? It's that simple. And what do we tell our residents that we're doing to make sure that when they're sick, they can go get an appointment, not 3 weeks' time, but tomorrow?
Yeah. So in terms of general practice, there's been additional investment which has gone into general practice across Essex. We have also been working with general practice around supporting them to recruit to a whole range of additional roles, so paramedics, pharmacists, nurses, etc. And so they should start to see that difference over the course of the summer. And if there's but if anybody has got specific concerns around an individual practice, they can let me know, and we can have a look at it. Because so that's that piece of work. In terms of kind of waiting for like a hospital appointment or something like that, that's part of the £20 million we put in this year to get the waiting list down by 40,000, is to start to try and help clear some of that backlog, and so we can get people who aren't waiting such a long time for their outpatient appointment.
That's great, but when I tell that to our residents, I know the question they're going to be asked, well, we can't get referred to a hospital until we can see the doctor.
Yeah.
Do we have metrics that show the improvement that we're getting in waiting time to actually see GPs?
Yes, so we have data that we can share if that's useful here in terms of the total volume of GP appointments being offered, how fast someone's being seen from requesting their appointment, so what percentage are seen within 24 hours, 48 hours and longer. And equally, we've also got data in terms of, so we can show this is the total waiting list size for outpatient services and so on, so we can track all of that. And so that's something I think we can start to bring through this board, so you can see how we're doing, and we can have a conversation about where we're not on track, what we're going to do about it.
Yeah, I mean, that'd be good. So if you could share that with certainly the council to see it, because we're the ones at the sharp end are getting chased about it. So we would appreciate that, please. Thank you. Sorry. Substance. I keep pressing yours, and you're doing mine, so that's good. We're all doing each other's. Substance misuse prevention in schools update, please. Who's that?
Hi, I'm Natalie. I am the service lead for Open Road, specifically covering young person services. We've got 3 young person services, one in Southend, Thurrock and Medway, but for Thurrock, our service has been here since April of 22. And we're in partnership with Forward Trust. The Forward Trust are the main contract holders working with adults. Open Road is subcontracted to work with anyone under the age of 29. It differs a little bit from most young person services because they normally cut off at 25 if they're a looked after child, but we do go up to the age of 29 just to try and prevent young people and young adults from going into adult services, because our adult services in substance misuse caseloads are quite high, so it takes a little bit longer to get them through treatment. Our purpose is we've got smaller caseloads, we can see people more frequently, give them that intense support and hopefully get them through treatment quicker, preventing them from entering into adult services. Sorry, I should have said Michaela is our service manager covering our Thurrock service. Jump in whenever. But in relation to young people and why we're here today, we have had a bit of an update since the previous Health and Wellbeing Board that we weren't able to attend, but we've been very fortunate that we've been able to access some more funds. Our commissioners, I'm very grateful for her. She's managed to get us a couple of new roles that are school specific, an education link worker who is based within our Thurrock schools, and a vaping lead, again trying to tackle those young people that are starting off with vaping before moving on to other substances. We have also been fortunate to get a ketamine specific role, because we know that ketamine is up and coming in the substance misuse world. That is a split role between our Thurrock and our Southend service, but that is to be integrated within the hospitals, neurology, to build up those connections, to try and tackle those young adults that are presenting quite frequently with UTIs, but getting treated for UTIs and then discharged where they're not being honest about their ketamine use, and that we can then come in and try to deliver that harm reduction and with a view of abstinence. Open Road in general aren't abstinence based, we are a harm reduction based organisation. With the schools in particular, these two new roles are very, very new, only started in April and May, I think, the two new workers. We have had some challenges with schools, and I fully appreciate schools are extremely busy and they see a lot of young people, but they are the providers that see young people more than anyone else. So we are reliant on them to pick up the young people that maybe need our support and make those referrals. Young people don't refer into our service, under 18s don't self-refer, so we're very reliant on other professionals to identify and then refer into us for us to give that specialist support. We can do the professionals training to help identify those that may be misusing substances, but we just need that opportunity to come into the schools. Some of the barriers we have, I think, are that they're so busy. Safeguarding is a lot higher than it was when I started working in young people's even 5 years ago. The demands on core services is a lot higher. There's certain times of the year where they won't touch us at all, like now, GCSEs, and I appreciate that. But we have a lot to offer schools that's free, completely free, one-to-one support, professionals training, workshops, targeted workshops, education. All of it is free to the schools, and we're just struggling to get our foot in the door to be able to reach the young people in the community, to arm them with the tools that they need around substance misuse, what they may come across. They may not be misusing themselves, but they may know someone that is, and to try and support around county lines, exploitation, just to give them those measures and let them know that there's a service out there for them should they need that one-to-one confidential support to support them. Anything that you want to add in terms of?
We obviously do a lot of preventative work within schools, so we try and offer workshop sessions to local schools to help educate young people about substance misuse, the risks, and where that can lead to help prevent substance misuse within young people. So it's not just young people that are already impacted by drugs or alcohol, it's also those that aren't currently but could be at risk in the future as well.
And I think just to highlight one example, which I did put in my report, we was working with a young lady, 13 years old, and she was vaping. She was with us for hidden harm, which is also another provision. Young people affected by parental substance misuse, we support those young people. She was vaping herself. She was over at skate park over at Stratford, I think it was. Forgot her vape and innocently just said to someone else skating, "Can I just borrow your vape?" It was laced with nicotines. She got unwell, went to hospital. Fortunately, she's okay. They kept her in overnight and discharged her the next day. She's done really well since. We've stayed in touch. She's remained free of any vapes or any illicit substance for that. But the vapes are so dangerous now, and there's no way of identifying, really just by looking at it, what it's got in it. We did test her. It's not a normal procedure to test a young person, what they've got in their system, but to enable us to provide her with the support she needed, her parents were okay with us testing her, and that's how we knew there was nitazines, which is a synthetic opiate, and it's being used to cut in heroin basically. So that's the level of what we're sort of looking at and having challenges with at the moment. A lot of them are laced with spice. Since we've had the disposables made illegal, I've not seen any positive impact among our young people with the disposables being taken off the market. They aren't, if anything, I think it's had the opposite because they are seeking them through other methods. They're getting them from like drug dealers, which is more challenging for us. And vaping, we have the message of if you don't smoke, don't start vaping. If you don't vape, don't start vaping. That is our message. But it is seen as a cool thing to do, if you like, among young people, and that neurodiversity has risen in the last, I would say, 4 years among young people. Quite a few undiagnosed, and they do use some sort of substance, whether it be a vape or cannabis, but to help cope with their own triggers with their neurodiversity, which is undiagnosed. So we can support with the other coping mechanisms and signposts to help them with their getting their diagnosis, but these are some of the challenges. It is that substance misuse is so vast now, and I've been working in the industry for over 5 years and I've never seen it move so quick, especially among our younger generation, and that we're watching our ketamine data at the moment, and it's known as a young adult substance, and we're watching the age get lower and lower, and it's purely because of how cheap it is. You can pick it up, like if a young person was given a £10 pocket money for the week, they could easily go and collect a fair amount of ketamine for £10, and we're not seeing them using it as they used to at a party scene, at a house party. A lot of substance misuse is isolated within the home, within the bedroom. So for us, Michaela's excellent at our social media and and I'd really welcome support with pushing our social media, because that's how we're trying to reach these people that aren't in the community, that are using at home. How can we get them to get the support that they need? And right now it is through the use of social media, and it is working. It's having a slow intake, but we are slowly getting people responding to our social media posts around ketamine, cannabis, just saying, I'm struggling with this actually, I could do with some support. So we know that it's the way forward, but we need support with pushing our social media channels out there to reach as many people as we can. Anything from you?
Don't think so, I think you've covered it.
Any questions? We're happy to.
Just to give a little bit of context to everyone as well, the drug and alcohol treatment services are funded by Public Health through the Public Health Grant. So we have Forward Trust, who's our provider, that provides an amazing service to adults, and Open Road, which focuses on children and young people. I was lucky enough to visit last week, in fact, on Thursday. So the service is based on Orsett Road, and I would welcome any Health and Wellbeing Board members who want to learn more and visit the site, because you really do get a sense of who's coming in and also what the kind of challenges for the services are. They're co-located, which is really helpful, and following discussions with Open Road, we have used some of our grant reserves to invest in getting those 2 additional posts, which hopefully is kind of starting to make a little bit of an impact. I think the challenge, and I'll kind of bring Sheila in on challenges for schools, because there's so many things that from public health and other areas we want to engage with. So it's not just here, I think, in Thurrock, it's more widely. There's lots of organisations that want to engage, but I think having some dedicated resource for that is hopefully going to make a bit of a difference. I guess the relationship with schools, just to highlight, is one, it's proactive, which is giving information to assemblies and having that engagement, and then reactive, which I understood to work quite well if there's a pupil who's having challenges, that schools know to contact you, that the service exists, and that felt like it's working quite well. I won't go on about vapes. I guess the kind of key public health messages are, obviously, if you do smoke, then vapes is legal vapes are useful for you to stop smoking, but the message to children and young people is not to start on vapes, and so it can be quite complicated. There's a lot of national work done by ASH that picks up how children and young people get access to vapes. So there's lots in this space, but quite often it's through other individuals. They're given it, or and we do work very closely with our trading standards colleagues. Mike Deneen's fortunately not here today, but we do work very closely with them, who check a lot of the vape shops for any illicit products, basically. But again, there's a lot going on in this space already. But we just want to say thank you for coming here and raising awareness on all of these topics.
I'm curious to understand what the size of the problem is. Do you have data on how many children and young people are actually misusing, or where they are being harmed by other family members and friends misusing?
I think for us mainly at the moment it seems to be more greys. We do stretch out further. My concern is because of how Thurrock is set up, those outskirt areas that maybe can't get access to us as easily, and us accessing them. So the main locations around Grays, you've got the train station, we are able to access, and we can see that there's a wider issue there. I know that there's a wider issue further afield. It's just getting to those outskirts areas of Thurrock.
But do you have any numbers?
Not on me right now.
No, I appreciate. But you actually understand the size of the problem as well as the complexity.
Yeah, we have the data around it.
I think that would have been helpful in the update for the Health and Wellbeing Board. Thanks.
First of all, great piece of work. I know we work closely with our SETCAMS service with Open Door, given the sort of cross work between mental health and some of the cases that you work with. Just want to bring to your attention that we've recently did some reviews around solvent misuse. I'm sure you're aware. And due to 2 child deaths in Essex because of solvents specifically, we did a bit more research in terms of that within our mental health service. And Sheila, I'm sure you probably would have got some of the reports on these, but what we've found is that solvent misuse is increasing quite rapidly in the last sort of 5 years. And you were asking Margaret just about data. I could tell you, I'd be interested to see how it affects Thurrock. But from 2015 to 2020, we had 220 deaths just from solvent misuse. And the issue with solvent misuse is that it can happen any time, just like that. One solvent use, you can die. We've had 44 deaths a year, and in 2020 alone, we had 38 deaths associated with solvent misuse. So the reason I'm bringing this up is that I don't know if you want to link in with us, because we think there's a bit of work that we have concerns, because until we looked at that child death, those 2 child death reviews, and did a bit more work through our safeguarding team, that we realised it's a lot more of a pandemic than we realise, that it just seemed isolated. We had on Friday, the Essex Mental Health, the strategic board meeting, and with our colleagues in the police and other partners, we realised that actually they're picking up a lot on there. And obviously it's not until you sort of come together and start looking in the bigger picture, you realise how serious solvent misuse are. And I think because people can die so quickly, I'm just wondering if, in terms of investment support to Open Road, I think that might be useful. So, to you guys.
I was kind of aware from CAMS about these 2 deaths. Some of your colleagues had made me aware, and we are seeing a slight increase in referrals for solvent abuse. I think the difficult thing with it is a lot of young people won't name it as substance misuse, and it's a lot harder to identify because the signs of substance misuse are going to look a lot different. So I do think we need to kind of explore the ways we're working with solvent abuse. and how to identify those cases a lot better to provide that support.
Yeah, so what, just for clarity, what we've done within SECAM, so this also again fits within our Thurrock team, is once a young person has an assessment, that question is quite clearly being really specific around solvent misuse. That's then escalated to our high-level risk team, where we look at all of that and we either decide making sure that people go through the safeguarding, the referrals, the plan, given the high risk of death, and then we step it down, and then depending on the referrals and where it goes. So at least we've got an idea of what's happening in the area. So again, I would just suggest if you want to have a conversation with our team, we can offer support just in terms of being able to identify it. I think it's a challenge, and it's getting worse, and I think it's just important to we are aware of it can affect the Thurrock young people quite severely.
Thanks, Jodie, for raising that, and really helpful, Michaela, to get that link up. I think just two things. One, I'll certainly take that back as an action for our kind of public health lead and commissioner to join that up with the meeting. The whole area of substance misuse, there's a set DAP meeting, so Southend, Essex and Thurrock Drug and Alcohol Partnership, which is a partnership meeting to talk about some of these issues. So what I will do is I'll highlight it with our lead, and she can escalate it, and it can be picked up over there as well, and then I'll make sure we're linked in.
Yeah, as I said, our safeguarding team have pulled together a really good PowerPoint presentation, which we've shared with the ICB on that end, and we're happy to share it to make it easy.
Okay. I was just going to respond to the issue about schools. I mean, if you've come to the head teachers forums, they are the best ways of accessing as many head teachers as you possibly can. I think it might be worth targeting some schools like the Olive Academy. Are you already in Olive? Yeah, so there'll probably be a lot of young people there that this might be an issue for. And are you involved with the Children's Social Care Services? So you've already got those links, okay. So I think if you're looking for the bigger links across more of the academies, it is trying to get into those, and it is iterative. You can't just go once, you have to come again, and if you have any literature, that can be emailed out, then, we could make sure that happens as well, sort of centrally, that goes out to the schools. That's probably the best way. But as I think some of it's word of mouth of schools. If they have a good experience of services with some of their young people, they will then promote it to others to say, actually, this was really good, positive for the school. And I was just thinking as well, are you involved with our youth offending service? So you're already linked in with those sort of...
We've got a specific worker that's linked in with youth offending. So we've got like a young person's criminal justice worker who goes across youth offending and probation. I don't want to knock the work that we have done with the schools over the last 2 years. We have got some really positive engagement. Like Olive, we're in there every single week. And then there are other schools that are regular referrers. I have been to the I think it's a 12 to 25 strategy group, which goes every quarterly. There's a lot of teachers in there, so we attend that each quarter. Been in the newsletters every quarter, so we're doing everything we can, and I do know that the schools are busy, which is why we've now got this role. It's to try and alleviate the pressures from the school, and that this worker can go in and say, right, who have you got? I'll do the referral for you. Try and take away a lot of the pressures that we can, just to try and help them, but to also reach these young people. So it's the regular schools. We've probably got about 7 maybe regular schools, but there's a lot more schools in Thurrock, including primary schools, that we do also support. So in the grand scheme of things, we're only really just touching the surface of the schools.
Okay, I've got a question. I've just finished working a year in Olive, actually, in Thurrock, so I'm working very closely with them. Now my question, and this is probably my stupidity or ignorance if you like, if you've got young children that are going to their teacher and they're sort of talking about their drug take on or something like that, yeah, How does that then sit with safeguarding? Because the teachers obviously have a responsibility who they can report that to. So from your metrics point of view, how does that, if there is any conflict with like safeguarding of the young person who's reporting it?
As part of the school safeguarding, a referral should be made to us, and then we manage safeguarding our end if there's any referrals that we need to make in terms of social services if needed, if identified. But if the school identifies, say a young person comes in, or the most common one, they get caught with a vape. They don't tend to openly say, I'm smoking cannabis or I'm vaping. It's normally they smell of cannabis or they're caught with the vape. In our experience, although I do believe it's getting a little bit better, the normal reaction was suspend or expel, and we weren't seeing the referral. It was being identified that there's an issue going on around substances, but it was just suspend them and that was it. And we had an incident in our South End service, and it was our worker's brother who got suspended, and there was no referral over to us, and we only knew about it because it was her brother, and she went in storming saying, where's the referral? Like, we didn't even get that. So part of the school's safeguarding process, I suppose, should be, you've identified it, referring to us, and let us then manage that. We can communicate as to what work we're doing. It is confidential, but we can say, yes, they're engaging really well. It looks like they're reducing. We don't give out everything because we want that trust from the young person. But from my perspective, the minute that it's identified, a referral should be submitted, and then let us pick it up from there.
Sorry, thank you. I think you probably heard me anyway. But we are assessing the opportunities for engagement, etc. Is that kind of the agreed consensus, yeah? Mm-hmm. So we've satisfied that requirement, I believe. Okay, thank you. So now we can go on to the next one, which is the Better Care Fund. And I'm not sure which one of you would wish to speak about it. Okay, thank you.
Thank you, Chair. This is a report on the Better Care Fund plan for 2026-27. It's a plan which we have developed and already submitted to the Department of Health and Social Care. It's a mandatory requirement, and another part of the mandate is to bring the plan here to you for your sign-off. So that's what we're doing here today. A little bit of background. The Better Care Fund plan has been with us for around about 10 years. It's about the changing the way we deliver health and social care so that they are delivered in a more integrated way, that they work better together, and the focus is particularly on older adults, people aged 65 and over, and helping those people keep out of hospital unless they really need to go to a hospital, and to leave hospital in a timely way with the sort of care and support that they need that keeps them well at home. So that's really what this is about. The plan is appended to the report here, and I'll make some references to that. There's two parts to it. One is a narrative plan which responds to a number of questions posed in a template that we have presented from the department, and then there's a numerical template which in part sets out the financial plan, but also sets out a number of key metrics that we're required to address. So again, the focus is on working closely with the NHS, and so closely linked to the NHS 10-year plan, and with that moving services, transforming services to support the shift from sickness to prevention, and to support people to live independently at home wherever possible, and moving services from hospital to home where that's also appropriate. So that's the objective here, and set out in the numerical part of the plan is the range of services that we're investing in to try and achieve those objectives. The Better Care Fund plan has a number of different components to it, which are listed on page 46. Those include a specific contribution from the NHS towards the plan, and something called the Better Care Fund grant, which is available to local authorities, and the Disabled Facilities Grant, which is best thought of in the main as being a capital grant which pays for adaptations for people who need changes to their home to be able to live well. So, for example, ramps and wet rooms and rails and so forth. So those are the elements of the plan. In total, a number around about £25 million this year. Now, a requirement of the Better Care Fund plan is that those funds are put together, those three elements put together in a pooled fund, and then that is, in this case, managed by, or rather overseen by Thurrock Council under the auspices of the Health and Wellbeing Board. So very much a fund which is collected together with the purpose of keeping people well at home and out of hospital unless they need to be there, and trying to improve the delivery of services so that we can see people get the best service in health and care that they can. The plan for the current year, as I say, has already been submitted. That was sent in on the 19th of May, and I have to say that we have, as part of that, some metric targets. We are required to report to the board quarterly on non-elective admissions to hospital. So that's one of the measures that we have, emergency admissions of older people. We also have to report on the delayed discharge, in particular the average length of delay for a discharge. And there's two elements to that: the proportion of older adults discharged on their discharge ready date, and then for those who are not discharged on that date, the length of the delay. And then there's another metric related to the number of admissions to residential nursing care for people aged over 65. And for your information, the ambition there is to reduce the number of people who are going into long-term care so that we can help people keep well at home. Now, referring to the plan, the detailed investments from the three funds that comprise the pooled fund are set out on page 61 and 63. Now, page 63 gives you a list of all of the services that those funds are currently going towards. We could talk about those if that would be helpful, but perhaps you could just, for today, note that there's a broad range of services, including the By Your Side service, which was mentioned at the last meeting of the board. And those are the services which we'll be overseeing the performance of and reporting to you in terms of the three metrics: so emergency admissions, delayed discharge, and the reduction in the long-term admissions to residential care. In relation to those metrics, I need to say that those are set out on page 67, and because this report was published last week, it contained an earlier version of the plan. We've had a discussion with the Department of Health and Social Care about the ambition that we have for the average length of discharge delay. Now, obviously, the total ambition would be to not have any delays whatsoever, but for a variety of factors, that's never going to be possible. The initial ambition was set at 80%, and we've increased that now, with the agreement of the department, to an average of 91.3% over the course of the year, and within the year seeing some seasonal variation on that. Now, for the minutes, I'd just like to record that there's been a resubmission on that metric, and I'll make sure that it's recorded in the minutes so that you have the full up-to-date and agreed metric that we will then report to you on during the course of the year. Now, I mentioned that there's a pooled fund that's overseen by the council on behalf of the Health and Wellbeing Board. The requirement there is to set up a Section 75 agreement between the council and the NHS, in this case Essex Integrated Care Board, and so we'll be doing that. We have first, though, to wait for formal approval following an assurance process on our plan, and we hope to get that over the course of the summer, and then after that we'll be in a position to put the legal agreement in place for the administration of the Better Care Fund for the year under the context of the under the terms of the Section 75 agreement. So that's the position today, Chair. We're presenting to you the plan. If you'll sign up, those are the key components of the plan. Happy to take any questions, of course.
Thanks, Christopher. Just in terms of the list of, I guess, initiatives that are funded, do we have an understanding yet in terms of whether additional funds would be, like what the outcomes are of each of them as a comparator, so that we start to think about if an additional pound is made available, where is it best to go across those pots, or is that not yet available?
Well, in relation to that, we will be reporting to Health and Wellbeing Board through the course of the year on the performance of those services. I should say that we have, over the last 2 years, undertaken a line-by-line review of each of the services in the plan. So that's allowed us to do, as you say, identify any funds that could be freed up and reinvested in new services, and that's an ongoing process. So we continue to set objectives for each of those services, to monitor performance against those objectives, and in terms of the totality of our objective to help people to stay well at home, looking to adjust those services during the course of the year where it's appropriate. So we'll come to you from time to time with suggestions about how we might be changing the direction of the pattern of investment in services.
Thank you. The reason for the question is just purely because the Thames Freeport is also investing in the Careport project. It'd be good to know where we should benchmark our project against, and how we feed that into your fund and do that as a comparator. So selfishly, that's why we're interested.
If I could just add a footnote, we certainly need to look at the Better Care Fund under outcomes-based commissioning. I think it would be fair to say that a fair tranche of the services currently funded through the BCF are well established, and I think that what we need to do, we've certainly had some initial discussions with Thurrock Council about moving the focus of how the services continue to be commissioned where it's appropriate to do so, and actually moving it towards outcome-based commissioning.
Update to it, some numbers, I believe you said. And one of the things that we're supposed to be doing is sign off the submission of the Thurrock Better Care Plan for 26-27. Yeah, but this plan that we've got is not, I think what you're saying is not actually the latest, is it? And there's some figures changed?
That's correct, Chair. It's in relation to the, on page 67, and it's the metric for the average length of discharge delay for all acute adult patients. And it's the line which is in this report shown as 80% throughout the year. We've submitted revised target for each of those months with a seasonal variation. The average of that 12 months is a much higher average length of discharge delay. That's to say the delay has been lessened, which is coming out at 91.3% over the course of the year. And I will get the full target updated in the course of the minutes for you. Yeah.
So on the basis of that, as regards, sorry, thank you. On the basis of that, on the sign off the submission, we're going to get an updated plan, which we've been told what the figures are. Yeah, is everybody happy to agree it? Yeah. Sorry.
Is there benchmarking data? Because it's interesting to hear that it's 80, but I don't know if that's really good or just average or actually terrible.
Yes, indeed. We report quarterly to the Department of Health and Social Services the performance against the three metrics, including the average length of discharge delay, and we've just submitted the 2025-26 end-of-year report, which covers those 4 quarters for last year, and in fact the new delay target is more closely based on performance last year. So we are seeing a pattern over the years, and the expectation is that we will see improvement over the course of time as well. So yes, we've had a significant correction to this 80%, and it now reflects how we're performing in the course of last year.
That metric you were just asking for, would you like that to be included in subsequent minutes, the report?
Yes, please, because I mean it's hard to judge whether we're performing well or and you didn't I know you said you've just had the return, but you didn't say what that. So is 80% now the national average, or is it?
Well, the performance in Thurrock is considerably better than 80%. That's what we've achieved over 25-26, and we've brought the current year's plan in line with that. And as I say, we would expect to see further improvement as a result of the initiatives we've got in place.
Sheila, we can also provide a trend analysis over the last 2 or 3 years, if that helps, to give you that baseline and that benchmark.
Thank you. I think it just helps to be able to know if what you're telling us is much better or sort of plateauing or a little bit worse. So that'd be really helpful. Thank you.
We did have a little bit of a preamble before the meeting, so some of the data was kind of shared earlier, so that's why some of us are not asking too many questions, but I welcome the questions. Any more? No? So based on that then, Sheila, are you saying that you don't think that we should be signing off the submission at this point, or? Sheila? Sorry, are you saying then that you're not happy to sign off the submission of this plan until you've got that data?
Sorry, I'm not saying that. It's nice for the board to have that data at in future meetings.
But you're happy for us to, yeah, okay, thank you. Even when I press it, it don't work. Healthy weight strategy. Again, 20 minutes and 10 minutes and 10 minutes. So Beth Caper will now present this item, I believe. Thank you.
Great, thank you. So the Health and Wellbeing Board approved this strategy in 2025. So we're a year in to the delivery of it. This board receives annual progress updates on the delivery of the strategy to provide that strategic leadership and accountability. So this is the first report that we are bringing to the Health and Wellbeing Board, and it's a 5-year strategy, so it's running from 2025 to 2030. So just setting out the problem, which I think many will be familiar with, but obesity is a significant long-term health challenge. It's associated with reduced life expectancy, a range of health conditions like type 2 diabetes, cardiovascular disease, many cancers, liver, respiratory disease, some mental health challenges. So the page 72 includes a visual which sets out some of the local picture for Thurrock. So you'll see there measures around our reception and year 6 childhood obesity. There's a national measurement programme in our schools where we track the weight of reception and year 6 children with the consent of parents, and it provides a really helpful kind of year-on-year measure. And in fact, we have since producing that infographic received the latest figures for reception in year 6, and they have gone up since those included in the infographic. As you can see, we also have 2/3 of our adults who are living with excess weight, and we've got high levels of physical inactivity, both amongst children and amongst adults in our borough. So the Healthy Weight Strategy, approved last year, sets out 7 strategic priorities, and again that's set out on page 72 in the first visual at the top. So we are supporting children and young people to grow and be a healthy weight, a priority around food security, around access to trusted information and resources, supporting employees through healthier workplaces, healthy place shaping, promoting physical activity, active lifestyles, active travel, and promoting healthier food choices and the environment. So for the first year of the delivery of the strategy, we have a cross-sector healthy weight steering group, and we've created 4 work streams to deliver those priorities, 3 of which are active, and the 4th will be starting very soon, actually. So just to, the report includes kind of detail of updates against those work streams, but just to pull out a few examples of progress over the last year. In the early years and families work stream, we now have a full weight management offer for our early years and children, and we're now commissioning NELFT to provide that offer for our 5 and above. And the family hubs are supporting early years with nutrition and cooking workshops. We call it the Henry programme, but that's a national programme. It's health, exercise, nutrition for the really young. And we're offering Henry across the borough as well. The Brighter Future strategy, setting out our ambition, and Sheila can speak to this, but has been revised, and so that we're aligning the healthy weight work with the Brighter Future strategy for children as well. So there'll be alignment and perhaps an update to that early years ambition on the back of that. In terms of the food security and environment work, we're expanding our food pantry. We've currently got a great food pantry in Purfleet, and we're in the process of creating a second in Tilbury, and that will be launched this year. We're creating or setting up the Thurrock Food Partnership. There's some great partners already engaged, and bringing those together in a more cohesive way to look at the food security and environment. And we've got a food coordinator recruited to support that process. There's a really great food growing pilot going on in South Ockenden involving 5 schools and the community there. So there's some fantastic work that has been started there. And we're also working with our planning colleagues to make recommendations around supporting healthy food options and considering health in our local planning decisions. In the physical activity and active travel work stream, we've got a fantastic programme of work underway through the benefit of a Sport England grant, which brought £1 million into Thurrock to spend on physical activity. So as part of that, we've got a range of activities. At the moment, Beat the Street is going on in Tilbury and Chadwell, and we've got 2,300 players more over a month who are kind of wandering around the wards, checking in and getting young people and their families to move more in that area. We're also doing some training around SEND swimming, so training treetops teachers and Impulse Leisure staff around SEND and swimming lessons. And working with our strategic transport team to look at active travel. We've got 2 schools engaging in that partnership. So the paper also kind of looks to the coming year. What will year 2 look like for delivery of the strategy? We will be looking across the 4 work streams to think about health inequalities and enabling communities, so that community engagement in a bit more detail. But for early years, there's going to be a new role around infant feeding and promoting awareness and uptake of our offers. We've got some great stuff in place, but we want to increase access and uptake of those, and some more training in nutrition and healthy eating across the workforce. I mentioned the Tilbury Food Pantry for food security and environments, but we want to look at what nutritious food in those spaces looks like. They've got cafes in the pantry, so how do we get good food and healthy options embedded there? And doing some community work to understand what the barriers are and awareness around healthy eating to inform some of the activity that we would want to be doing in the future. For physical activity, we are recruiting for an active environments officer to prioritise active design in the way that we're planning our spaces, thinking about the safety of our green spaces and recreational spaces, as well as what facilities are in place there. And I've mentioned some of the community activation programmes like Beat the Street. We've got a Bellis community run. Big lunches will be starting again this summer, so getting the community together but active in that way as well. And we've also been invited to submit as part of been invited to the second stage of an application with Sport England around a cycling infrastructure proposal, which is really exciting as well. The workforce work stream will be getting up, and we'll be thinking about how we support employees in their work settings. So that work will be commencing soon. So yeah, there's more detail in the report, but really happy to take any questions. Thank you.
Thank you for bringing this. It's really, really helpful. It is a priority for the Children's Brighter Futures policy and programme, because talking about benchmarking, I know that we've got significantly more children at year 6 overweight or not with a healthy weight than the average. So we really want to focus on this because it impacts on so many different things. So it's not just about the weight, it's also lots of other things for children. So it's really good to see all the work that's going on and what people are doing. And I know the family hubs are very involved in helping to move that forward and taking it forward on a local level where parents are comfortable to come in and to talk to people. So I just think it's really good to see this. We'll probably have it at Brighter Futures again soon as well. Thank you.
Thanks.
Just to echo Sheila's points and say thank you. The team is leading this strategy, and it's kind of cross-council, cross-partnership strategy. I think I just kind of want to emphasise a kind of couple of key points. I guess firstly, it does take time. This is something we're not going to fix in the next quarter, so just to kind of be mindful of that. It's often to get these outcomes relates to behaviour change of individuals and culture change within communities and groups. I guess the second point I wanted to make is that we all have a role to play. So this is it's really helpfully set out different work streams. The work and health one is yet to kind of take flight. I would look to our large acute and community trusts to see whether there's something that your trusts are doing in terms of as employers, also something for us to think about as a council. But if there's if there's people in the organisations who are keen as champions or are working on this, to definitely link in with either myself or Beth, because we want to kind of take a systems approach to some of this. And yeah, just to emphasise the importance, this runs across the life course. So some of the work is with mothers-to-be, pregnant women, and then also the importance of breastfeeding all the way through life. And when you're, up into an older age, and just huge impacts. I think we haven't kind of drawn it out in this report, but not to underestimate the impact on mental health and physical health. And Tom, just hearing about the, I was going to say population health improvement priorities, a lot will link into long-term condition management as well. If you're active and you have hypertension, then you're going to have better management of your long-term condition as well. So there's a lot around it that's not in here, but there's a huge amount of work going on and huge benefit to be realised if we can get more active as a system, and for our residents to be more active too.
Well, my note here says that there's 3 elements that we have to consider now. It is recommended that board members, first of all, note the progress made in 25-26 to deliver the healthy weight strategy, which I think we have all acknowledged that. And the second one, endorse the proposed priorities and delivery plan for delivery of the strategy in 26-27. Does anybody disagree with that? Or yeah. And thirdly, champion the healthy weight strategy across their organisations and partnerships. I guess that's kind of really just a statement that we all commit to. So I think we tick all 3 of those boxes, yeah? Okay, thank you very much. Yeah, thanks, Beth. So I guess the last item, conscious of the time, you said you have to leave at 22. I think we're going to be fine, aren't we? Yeah. So the last item is the work programme. A copy of the work programme is provided on pages 91 to 94. And it's basically, if any members, I guess, have got anything that they think should be, shouldn't be included, or if there's anything else they'd like to add. Yes, go on.
I think at the last board we said we would bring for the September meeting an update on initial health assessments, because there's a new programme and a different way of working with initial health assessments, which has been a stubborn, very difficult initial health. So this is initial health assessments for looked after children. It's been stubbornly low and not performing well, and at the last board we had a presentation about a new model and some extra funding going in, and we said we should bring it back in 6 months, which would be September, to see if it's made any progress. We're hopeful.
I think, Tom, I messaged you, but to say that from the Thames Street report, we're happy to do an update in the September board to say what we're planning for this year and what will be underway, but also come back in the January to report on progress and see as much as possible where things overlap, because given the discussion today and at previous boards, it seems sensible for us to keep doing that if there's space on the agenda.
Yeah, just looking again at September for the set suicide prevention item, EPUT was due to present as part of the Essex Safeguard Suicide Prevention Board for Essex County Council in the last municipal year, but for reasons I won't go into, that meeting didn't happen in the end. But we did an informal briefing to their People and Families Committee, so we could also support that item.
Sorry, Margaret, I had to check your name first because I've got such a short memory. As I say, before we had the main meeting, we did have a bit of a briefing with Margaret, and she very kindly offered to run some training courses for people who need more information. And I'm sure you wouldn't mind if I extended that to everybody who thinks you want more information. Please let Margaret know your names, etc., and she will run whatever training might help us.
Could people give their details to Dominic?
Yes.
Yeah. So I know there's at least 3 of us around the table that will probably appreciate all that support. So. Is there any other points before we finish? So I guess that brings it to a close. Yeah.
Time.
The time is, by my Apple Watch, 3 hours and 17 minutes. Are we all agreed? Or 15:17, if you like. Yeah.
Declare it closed.
And I therefore declare this meeting closed. Thank you all for your attendance and look forward to